We're up? Okay. Well, it is 10:04, and I'm going to call this city council work session into order. I appreciate everybody being here today. It's twice this week, or in the last 12 days that we've had to meet during the daytime as well, and I appreciate everybody's participation in that. I want to say thank you to our 4 guests for volunteering to be here today. First, we have Dr. Sheffield, who is our state representative from District 59. Dr. Hutchins is coming from, he just texted me, he's running a little bit late. He'll be here in just a few moments. We have Dr. Kelly Doggett, who is our current, the official title is Health, what? Local Health Authority. We have Dr. Brandon Nash at the end, who is, at one time, he's still the president of SMSC. So I invited these people individually for reasons, which hopefully we'll see that at the end. I'm sure we will see that at the end of this meeting. So I want to thank you for y'all being here today. We have scheduled this for no more than 2 hours. So I told everybody I'm hoping we get out here before that. But the purpose for today, the goal I want to have come out of this meeting today, is to educate the council on the virus itself, the spread, et cetera, and have some conversation about that, because I'm sure, well, I'm not sure, I know, because of all the emails I've received from councilmen, councilwoman too. I want to recognize Carla there. I want to make sure that everybody has the same information, because every one of us has read CDC stuff. I've read it so often, I think it's in my memory on my computer, so when I start typing in C, it just pops up there and goes. So everybody's read all that stuff, but all of us have also seen and sent to each other dozens of other documents that say, yeah, that's right, but, or here's some more information. And so I've asked these people here to give us some input. Dr. Sheffield is going to talk to us about what the state of Texas is doing. He's on the Public Health Committee, and we'll have some information for us on that. So we're going to get started today, and I'm just going to kind of go down the row if you don't mind. And I have some questions, and each of the doctors they all say each other's questions. And so I'm just going to I bundle them together under certain names and ask if they had participated in this. The first one is, Dr. Nash, would you please explain the origins of the virus, the pathology of the virus, and why it's so different from what we've seen so far, and what we're hearing from patients and others in our community about the virus?
Sure. So basically, as most people know, this originated in China, and it's a SARS virus, which we've seen SARS virus in the past, but it is a little bit different. It spread, from person to person through respiratory droplets. It can also live on surfaces, as I think most people have heard. They're doing some studies now to try to figure out exactly how long, but the consensus is mostly that up to even 3 or 4 days on some surfaces that the virus can live. But its main, and so a lot of times it is transmitted not just through people coughing on you or sneezing on you, but an infected person touching something and then you coming behind them and touching them, and then transferring that to a mucous membrane, so touching your face, eyes, nose, mouth. So that's the main mode of transmission there. Symptoms can range all the way from none to complete respiratory failure and death. So the main problem with this virus is that a couple of problems. One is that it's a novel virus, so a lot of people don't have any immunity to it at all. In fact, nobody does until they've actually been exposed and infected. Secondly, there's a higher fatality rate than with some of the other viruses. This particular virus can lead to significant respiratory issues, respiratory failure. Acute respiratory distress syndrome is what we call ARDS, is the main big concern with a lot of these people. So they can go from a pretty minor cough or respiratory symptoms to all the way to ARDS, which is respiratory failure in a very short amount of time, requiring ventilatory support. And that ventilatory support, instead of maybe 2 or 3 days that you might see with pneumonia, can be up to several weeks. So that's kind of the main concern as to why this virus has been so much more significant than other viruses in the past.
How many folks have in the nation, and all y'all have, please ask questions as it comes up. Dr. Hutchins, how are you, sir? Is how many folks are ill that don't present symptoms? That's one thing is, well, I've been around somebody, but they didn't cough, they didn't have a fever, et cetera. Talk about that a little bit, because that's when it gets down to the community spread issue. That's really where it boils down to.
Right, and the problem to that is we don't know. I mean, if we could test every single person, then we would know the answer to that question, or have a much better idea on the answer to that question. But that's not at this point a possibility, and so there's, I think, likely a lot of asymptomatic or very minimally symptomatic people that are spreading this, or especially in other areas of the country where you see more cases that are positive. But the answer to that is just we just don't know how likely or what the percentage of people that are infected. We just don't know because we're not testing everybody.
What about we hear about the self-test coming? If you talk about that, also about the lab machine that from Abbott, for example, because our city manager is in the process of looking at purchasing one, if that's possible.
Yes, the clinic, now the self-test, I have not heard an update recently, and if anybody else knows that, certainly jump in. I will say that from SMSC, we were actually, before the whole coronavirus took off, we were in contact with the same company that makes the same testing device for flu and strep, but they've added a coronavirus sample to be able to be run on the same machine. So when they announced that they were going to be, distributing these, we contacted them over the weekend, and they basically told us, yes, you're on our list. In fact, hopefully will be getting one or more before a lot of people, but their priority is definitely the places where it's more, they have, more cases, more people that are, in respiratory failure hospitals, that kind of stuff. So we're not on their top priority right now, but we have that in the works, and I know that our administration is continuing to check on that. We'll be continuing to check on that routinely.
If a government entity wanted to participate and buy one of those, would that punch us up the list of priorities any?
I don't know the answer to that. I can certainly talk to our administrator, though, and they can reach out. They have representatives that these companies do that we are in contact with all the time when we're buying and getting supplies for these. So I could absolutely ask that question.
If you just get that person to contact Jimmy so they can get in touch, because we're interested in doing one, particularly for our employees. But I know we've talked to Dr. Doggett as well about the use of it, et cetera. And I'll let him address that as well in a few minutes. But if we could do something to help our citizens, I think this council would be interested in seeing what it costs and what we can do to afford that. Okay. The other thing is, and my personal interest in this question is immune suppressed people. Can you talk about that and why the 60 and over? I mean, Alan and I are both over 60, and he is 4 months younger than me. He wants to make sure everybody knows that. But we're both over 60, and Carla is too. So we're in that upper bracket, but then my wife has an immune suppressant system. So tell us about that and what we need to do, what people need to do, because we've had some folks in town who may have even been exposed, et cetera, who are refusing to self-quarantine.
So I don't know that I'll have an exact answer for why, but for sure we are seeing that there are quite a bit more risk involved in anybody that in the categories you mentioned, people over 60, and especially the people, the other groups that we've seen have higher risks and morbidity are anybody with lung issues, anybody with cardiac issues, heart issues, morbidly obese people. Those are kind of the groups that they're seeing much more risk of respiratory failure, ventilatory support, that kind of thing. Now, and that tends to be in general with anybody or any flu, pneumonia, those kind of things. Any infectious disease is a lot of times more likely to affect those people more than others. And then people that have other immunosuppressed diseases or are on immunosuppressant medications for a disease, those people also are at higher risk. So at this time, and this could change, but at this time, there are not any further recommendations from the CDC on ways to prevent infection than what they're recommending the general population do. So for example, and I think I wrote them down just so I wouldn't forget any of them, but washing your hands frequently, trying to avoid touching your face. If you are sick, stay at home. One of the questions I get is, should somebody that's in that age group or an immunosuppressed patient be wearing masks and gloves all the time?
That's a good question.
And the answer to that at this time is no, unless you have symptoms. And the reason the answer is no is because they're worried that if that becomes the case, then we will not have enough personal protective equipment for the healthcare providers that are seeing these patients, face to face, that are potentially exposed. It may come a time when the CDC changes that recommendation and does want every person or every person over 60 or something like that to wear a mask and gloves. At this time, that's not the recommendation because there is still shortage of that PPE.
What would you tell and I'm going to stop here and let you ask some questions, but I have just one last question. What would you tell the general public who has been potentially exposed or has some other symptoms that has been diagnosed yet? What would be your instructions to that person as far as shelter in place? I don't want you to be real frank with them because we've had that happen recently and have had to address that. And and our police department's going to have to deal with it as well. So give us some recommendations.
My recommendation would be that if you either feel like you have been exposed or could possibly be exposed or having symptoms, even if you're having symptoms but no known exposure, I mean, I would say absolutely stay at home. No, you really don't need to come into contact with anybody. That's the whole idea behind this, push about the shelter in place, is to minimize any potential risks. And the other thing, I'll go back real quick on the people over 60 and anybody with an immune issue. I mean, that's really the thing you can do that will help the most, is to avoid getting out, to stay home. If you have a family member, somebody that can go get groceries for you, go get food for you, that would be ideal to avoid any kind of exposure as much as possible. But we have to be strict about this. I think people will probably talk about this later, but I've definitely seen, even since the shelter-in-place order has been put into place, that people aren't following it. And if people don't follow it, then we're going to have stricter regulations, because it's going to get worse.
Well, when we get towards the end, as I asked for a summary, that's one of the things I want each of the doctors here to address, is how strict do we want to get, on this ordinance. And also, I'll just say up front, all 4 docs know this, is that I've asked them to help us develop a step-up plan. Today where we are, Dr. Doggett is our official on that. Is it an adequate plan? And then if you go to step 2, step 3, how do you go down? What would be the triggers, if you would? So you all kind of keep that in mind as we're going forward. I'd appreciate it. Anybody have questions for Dr. Nash?
I do, just because it's come up, a couple of people have approached me. You talked a little bit about PPE. And so the official recommendation now is that don't use it.
Unless you're sick. So if you, for example, if you do have a cough or something, and in my opinion, if at all possible, anybody who's sick should stay home, period.
Okay.
Now, say you're a single parent with kids and you have to go to the grocery store or something like that, and you have a cough. I mean, they do recommend that if anybody has any kind of respiratory symptoms, then you should wear a mask in public. But what I was discussing was asymptomatic people.
Okay, so that was kind of where that question came from, because these were people that work in retail who have approached me and said, well, I really, for my own safety, I'd like to wear it. But right now, so I guess the second part of that question is, how do we effectively get that information out? That right now it's, the benefit doesn't exist, versus running out of the material where it is actually needed.
Sure. I mean, I would encourage, and just like you would do any kind of through this, televising this and Facebook and all the normal ways you can let people know the recommendations. But I do think the CDC website is very helpful and pretty easy to navigate, and it has recommendations and information for just lay people, healthcare professionals. For example, I was talking with my kids being in faith school. I was talking with the administrative people over there. They have specific daycare recommendations. I mean, if you go on their website, they'll give you quite a bit of information, and it's easy to navigate. And it's important for people to stay up to date, because, like I said, that recommendation could change at some point. If there are quite a bit more masks available, they may recommend that every single person wear a mask all the time. That's not the recommendation at this point, but if that changes, they would be the ones. The CDC website would be the first place to look for that.
Anybody else?
You talked about, he asked about, hopefully some of the advancements in testing. Now, I get a lot of questions. Can you kind of clarify for people what they should do if they do feel sick? What testing looks like now, timelines for that, so that people can be aware?
Sure. Yeah, at this point, and I would say if anybody has any upper respiratory symptoms, and specifically the symptoms that we are concerned about with coronavirus, fever is the #1 symptom, and then some other respiratory symptoms, for example, cough, shortness of breath. Those are the 2 big ones. There's definitely been reports that other symptoms are involved as well, sore throat, shortness of breath, some GI symptoms like nausea, diarrhea. So if people have those symptoms, it would be good to call their doctor. I definitely don't recommend just going to the doctor, going to the hospital, unless you're in it's a life and death emergency. But call ahead, because then you can get some specific recommendations. I'll tell you, just the way we're doing it at Stephenville Medical and Surgical Clinic is we have people at the door, first of all, so that there can't be people coming in and out with cough and respiratory symptoms. But when people call ahead, they're able to talk to a physician or a nurse practitioner or PA, And then we usually will have them come to our outdoor clinic out so that people can be seen outside with a healthcare provider wearing the appropriate equipment. And then if they do meet testing criteria, which at this point testing criteria is upper respiratory symptoms like I described, and either contact with somebody that has been tested positive or suspected of having COVID-19, or if they traveled in the last month. Now that can change again. Some people are doing 2 weeks, but we've been a little bit more lenient on the travel because we are seeing more cases. At some point, if we get more testing available, then that again, based on the CDC recommendations, we may test more people. Right now, if you do qualify for testing, typically a lot of times we'll do a strep or flu swab first to rule out those because they are more common. But if those are negative or if it's just suspected in addition to those, then a coronavirus or SARS-CoV-2 swab will be used. It's a nasal swab. It's not the most comfortable, I'll be honest with you. I actually was tested myself, negative, but it's not real comfortable. But basically you have this swab in your nose just for a second or two to get a good sample, and then that is sent off to a lab. I believe last I heard we are sending ours to a lab in Irving, getting results somewhere between 3 to 4 days, sometimes longer depending on a weekend. So that's where we stand now. We're really hopeful that will speed up I think it would be a game changer if we could start to get testing in 15 minutes, like we were talking about earlier. This new test that I was talking with the mayor would be 3 to 15 minutes is kind of what they've talked about for that one. And if we could get that, it would be huge. But again, that's kind of in the works.
A follow-up question to that, if you don't mind. So let's say what you're testing now are people who have some symptoms or maybe suspicion of or have been exposed. What would your recommendation to them in that 4 days wait? Stay home?
Oh, yes, absolutely. So when we see these people, we test them, and then we say, you go home, you self-quarantine. And again, in the CDC, there's some pretty specific guidelines about if they need a caregiver, if somebody is with them, it's recommended that person wear a mask when they're in the same room with that person, and that you try to leave the person who's quarantined in one specific room with a dedicated bathroom, and then cleaning surfaces frequently. That's another big thing that can help, but absolutely self-quarantine until they get the results.
Anybody else? Yes, sir.
First, I want to thank y'all for coming today. I know that y'all's schedules is busy as well, and I appreciate you coming. You mentioned that you test for strep and flu. Do you find this manifesting itself very often in combination with other diseases? And is it more contagious than these other diseases, which we're a little more familiar with?
It is more contagious. And if somebody else has more information down there, you guys let me know. But from what I've read, the virus is a little more stable and can live longer on surfaces than some of these other diseases. And so that's what makes it more contagious, is because of that. And what was the first part of your question? Do you find it manifesting itself? So not yet, we haven't, but I've definitely read reports of that happening. I've just kind of anecdotally heard from some physicians out over the in like New York and other countries actually that have found that the people will have flu and COVID together. Those are the people that are really, really sick on the ventilator in the hospital, and so I would absolutely assume that if you had a patient like that, it would warrant, that patient would warrant testing for both. I really don't know the numbers though as far as any percentage of co-infection rates. I don't know that we have that much information at this point to say that.
Thank you.
Anybody else? Yes, sir.
Can you talk about the notification process once someone has been confirmed, as far as what they're instructed to do, notifying people they may have been in contact with, or if the Department of Health is doing that, or what that process is?
I'll tell you from my perspective, and then anybody else down there can jump in. From on the clinic side, when we get a positive, we alert the patient first, is what has been happening so far. Basically telling the patient you're positive. Of course, they've been self-quarantined since they were tested, but also to tell that person to let anybody that they may have exposed know so that they can also self-quarantine, and that if any other anybody else that they've come into contact with has symptoms, they absolutely need to get in touch with their doctor to talk about potentially testing. And then, Dr. Doggett, do you want to talk about what's recommended as far as the other recommendations for?
Can you hear me? Actually, Texas Department of Health will follow up with that. They'll actually investigate it, backtrack, check the contacts, and then they will make recommendations. I know in hotspots, the National Guard is actually going door to door, backtracking contacts. So it is getting investigated. It will be followed up. Those people, all their contacts will be traced. But usually when it gets to that point, the state's taking that over.
Other questions? Okay. Dr. Hutchins, we talked a lot on the phone a few days, I guess, maybe not quite a week ago. And we talked particularly about the hospital, capacity of the hospital, et cetera. Would you talk about that a little bit? Because the big question everybody hears is, well, the hot spots in Texas are the DFW areas. I hear hotter than Houston. Is that correct? Am I overstating that? And then if it is, then that means those hospital beds are going to be full or filling up. And we have typically, in severe cases, been shipping that direction, in some cases. So tell us about the capacity here and what you're seeing on admissions.
Is this working? You go in the middle setting?
There you go. About that. Okay. Yeah, I don't know. I've heard that Houston was hard hit, so it was my impression that they were worse off than the DFW area. I can tell you that ER volumes are very much down, maybe half what they normally are since all of this started. Folks are staying away from the emergency room, so our volume's down. Acuity tends to be higher in times like that because you're only seeing things that are true emergencies. In some sense, that's kind of nice. I will tell you that I transfer patients frequently, and I rarely have an ER shift in Stephenville 12 hours that I don't send at least one, usually 2, 3, and sometimes 4 or 5 transfers to Fort Worth. I haven't had any trouble at all. Many times hospitals are at capacity, and so we try Texas Health Downtown Fort Worth first. If they're full or whatever, or a big ER backlog, have a bed hold situation, they'll say we're on bed hold. We could take it and hold it in the ER, but we suggest trying other hospitals, so we'll try Texas Health Southwest. And I usually go through the Texas Health system because we're part of that system here. And then frequently at that point we'll start trying other hospital systems like Medical City Fort Worth or Baylor, All Saints Downtown, or any of the other hospitals. Hadn't had any trouble at all with transfers. I think there's ample hospital beds throughout the DFW area. I have a close personal friend who is an ER doc at Baylor Irving. I talk with him via text message probably every other day just to see what the situation is there. How many patients are you seeing? How many COVID patients are y'all seeing? What's your hospital at right now capacity-wise? Are you running short on anything? And he's also seeing low volume. They're seeing a fair number of COVID positive patients there at Baylor Irving, but they're not anywhere close to being at capacity or turning away transfers into the facility. They're having to transfer people out because of any kind of shortages right now. As far as us, we haven't had a positive test in the hospital yet. I've had several that looked like if they didn't have COVID, I don't know what the heck it could be. And so that's led us into a little bit of a concern about the sensitivity of our testing. And right now, Dr. Bristerdine, just this morning when I got off and she was on, I'd followed up on several that I'd tested in the past 3 or 4 days. And the turnaround is still a problem. I tested one 3 days ago that I'm quite certain has the virus, and sent that patient home on self-quarantine. as well as the rest of his family, to be strictly self-quarantined. And been waiting for that test. It was Friday night, and still no test as of this morning.
That's a good question. We had a Facebook person just send in a question. And it's if someone is symptomatic, which I'm sure is why you did the test,
Yes.
but negative flu and strep, but they haven't been tested yet for the coronavirus.
Right.
How long should a person self-quarantine voluntarily?
Well, when we send them home, you're on quarantine until you hear back the results of your
Until you're
test for
back.
certain.
Okay.
And even if that test is negative, then as long as they have any kind of fever or cough or anything, I think they should be self-quarantined because, frankly, I think that there's at least, I'm going to guess, a 30% false negative rate on this test. I think the sensitivity is that poor. And I think there's some national data out there to support that. So I don't know how much we can trust the test. So I'm my friend at Baylor Irving and I had a big discussion, and he's diagnosing COVID patients based on some parameters lab-wise, and they're starting to become a diagnosis based on clinical grounds without doing testing that's becoming fairly commonplace in the emergency medicine world. And that is positive bilateral infiltrates on a chest x-ray, elevated C-reactive protein level, elevated ferritin, negative lactic acid or negative procalcitonin levels. And I think there was a couple things. I had all those criteria written down, but if you have those things, just consider them positive and start treating it as such, which is supportive treatment. You know, there's no treatment. But that's kind of the way it's going. But back to the original question as far as volume, here at the hospital, I know I checked the volume this morning, the census. I think we have 12 patients in the hospital right now. 5 of those are in the ICU. We have a 5-bed ICU, so we have no ICU beds. But a lot of times in the ICU situation, I know Miranda, Kelly, also test this. We have what we call movers in there, and those are people that we're leaving in the ICU just because maybe they're a little bit sicker or whatever. They could move out if we need to, and I think probably 3 of those 5 are movers. Could go out to the floor if they needed to. We just leave them in the ICU because of better one-on-one nursing and that sort of thing. And so I think we have 30 rooms upstairs or something like that. But as far as accreditation, I was talking to the nurse supervisor this morning, and our hospital here is accredited for 98 beds.
Mm-hmm.
We used to put 2 patients in each room, and so if it got real hairy or whatever, we could put a lot of people in the hospital.
Thank you. Any questions for Dr. Hutchins? Yes, sir.
Those tests that you spoke of that you could do in-house rather than doing the swab that Miranda spoke of, are those things that y'all are capable of doing here, or do you
Yes.
still have to send that out for the results?
Now I can get the results back immediately.
Okay, so that's your first line of defense, basically.
Yes, sir.
Okay.
Friday night, that guy with COVID. His official, COVID-19 test is still pending as of this morning. But he is COVID.
Just to add to what Dr. Hutchins,
If you'll talk right there. They're having trouble on Facebook hearing.
just to add what Dr. Hutchins said, he's right about sensitivity. In Wuhan, there were people having 6 negative tests that had it, and it got to the point where they were just strictly treating it clinically, and that's the way they handled it. I think our sensitivity is a little better than that, but it's like he said, it's not anywhere close to 100%. And something else just to keep in mind, we're not strained right now. They're not strained in the Metroplex, but as my associate, Dr. Massey from Texas Department of Health said, in a pandemic, you have a beginning, a middle, and an end. We're down here on the curve. Dallas is getting proactive. They actually converted the K. Bailey Hutchinson Convention Center to a hospital. And they're starting off with 250 beds with capacity for 1,400 beds just for COVID-19 patients. Currently, we're okay. yes, we're okay. They're okay in DFW. But it's kind of like Governor Cuomo said, look at us, look at New York. We are your future. And so that's where we're headed.
Yes, sir, go ahead. Go ahead.
I just had looking at some of the questions on Facebook, Dr. Hutchins, can you clarify? I think may have been some misunderstanding. You're not transferring COVID patients to the Metroplex. Somebody asked, so everybody's being transferred and the Metroplex is actually getting our numbers, and that's not the case, correct?
Well, as of now, we don't keep patients who require a ventilator as needed. So it's for the length of time that I've been back here in Stevensville Emergency Department for the past 3 years. We don't. If the patient's sick enough to need a vent, they go to Fort Worth, and that's just been the rule because we don't have a pulmonologist here. And I know Kelly's run a vent before. I know Miranda's run a vent before, and I've run a vent before. And we could run a vent, but our hospitalists here don't want to run a vent if they don't have to. So it's never been a case where we had to keep a patient on a vent, other than sometimes we have just because of maybe logistics. And so briefly, I've had patients in the ER for quite a long time, maybe 6 hours on a vent, and we manage those until the logistics of the travel or whatever, bad weather, no helicopter flying, all the EMS are tied down doing something else or on other transfers. So, sometimes we have to keep a vent patient here. But yeah, we have ventilators here and we can use them, but we typically have never run into a situation where we admitted for several days on end a ventilated patient here in Stephenville. We always transfer those out to Fort Worth.
Typically, we would want those patients to have
Louder,
a higher
louder in the
level of
middle.
care than what we're able to give
We're
here.
seeking a higher level of care. We want a pulmonologist.
It's like Jeff said, we can do that, but if it's a choice between us and a pulmonologist,
You're going to ship there.
we'd prefer
Ship
the
there.
pulmonologist take care of it.
And right now, there's not any difficulty getting the pulmonologist into the hospital in a bed.
Not
But
today.
not yet.
Not today.
And let me just follow up with a question related to that then. Dr. Doggett, you're part of the person who addresses. We keep talking about the peak will hit. And I heard the other day the peak in Fort Worth, Dallas is in like April the 9th or something, and that we should be a week after that. Explain what that means and how that could apply to what we're dealing with here at council.
Well, it's kind of like Marilyn Brister says, my crystal ball is cloudy today and I can't really see. Nobody can tell you that for sure. Estimates are a month to 2 months down the road. We don't know. Everybody's trajectory can be slightly different. It basically follows roughly the same curve. But I can show you, and I have some evidence that I'll show later about how different communities have different levels of spread and different velocities. But honestly, we don't know. A month, 2 months, we don't know. If you held a gun to my head and said, tell the truth, or I'm going to pull the trigger, I'd have to say, we don't know.
Okay.
Dr. Hutchinson, just a question with regard to the hospital. You said we have 31 rooms or 31 beds up there right now, but we're accredited for 98 beds, correct?
Yeah,
Do
that's
we
what I was told.
do we have the capability of doing 98 beds, and do we have the staffing for 98? To handle
Staffing, though, as far as nursing staffing?
Yes.
I think we do not. That's where we're, assuming there's this, this dooms, let's say we have a New York type situation where DFW is maxed out, can't take a transfer, and we're hitting our peak, we would find a way to do it. I'm confident in that. I know that we have enough medical personnel, nursing, et cetera, and doctors in the community that would pull together and do what had to be done if it got to that.
Listen, and the governor has relaxed some of the guidelines, and he's actually asked for retired nurses to come back to duty if needed. Retired physicians, they don't have to currently be licensed. So I think there'd be a call to arms, and I think you would see an answer if it was necessary.
Facebook, and related to that, someone's asked, how many vents do we have and what is our capacity for venting patients at the hospital? And then the second part of that is if we get overloaded, I mean, what's the chance of, we ship up to Fort Worth? Are there communities around us that ship to us on the way to Fort Worth, or do they all just go to Fort Worth?
And I think Dr. Markham has addressed that thoroughly on Facebook, that we have. It depends on who you listen to, 4 to 10 units. I think we have 4 dedicated adult units. With some anesthesia units we could potentially use.
I think that's about right.
Wouldn't really care to, but, if it's a situation like Jeff says, it won't matter because we won't have enough.
Okay. Are there other questions?
Did y'all catch the last part of his question about would smaller communities would Stephenville be considered higher care than some of the smaller communities around?
And I think that question should go to Jeff because he would be taking their transfer.
Okay.
I'm going to say no. I mean, so let's just say Comanche County Hospital has someone that needs a vent, if they have ventilators in their hospital too, and they would be facing the same thing. I don't think it would be a step up to hire care to come here.
Okay.
Now, if we had the capability and they absolutely did not, if we had to jump in the hero box, we'd do it. But typically we would, they would, at this point, would have exhausted everything else. Every hospital in Abilene turns you down, Brownwood even maybe. I think that would probably be an unlikely scenario that we would take patients here in Stephenville from other areas because we were considered higher care than they were.
Thank you.
Anybody else? I have another Facebook question. I'm going to ask Dr. Doggett to address this one. This comes off Facebook, and the question is, why can't we give more details about the patients who have contracted it, which allows the public to stay away?
I'd love to answer that question.
There you go.
I'd love to answer that question. There's a law called HIPAA, and it has to do with patient privacy. We cannot do that. We're bound by law. We cannot divulge patient information like that. There's protected health information, and it consists of patient's demographics, information about their past, present, or future medical condition, basically anything that personally identifies them. And then there are a list of 18 identifiers that we have to remove from their information before we can release it. We can't say this is patient X and they worked at here. I think what the public needs to do is just assume it's out there. Do what we ask. Stay home. If you're standing in line 6 feet from somebody, and 6 feet behind you there's somebody else, if you knew they had COVID, you wouldn't be in line. You'd be at home. So just assume that people have it and stay home.
I'll just say that's one of the reasons that in our announcements that the city has made, we don't ever put date of birth or age or that sort of stuff. Even kind of where they live for that very reason.
Actually, all we should do is just say we have a positive case in the county or a positive case in the city. They're very strict indices regarding that. We can say, a 24-year-old male or female tested positive for COVID in area 764 XX. We can't specify, that it was Stephenville, and 764 zip code covers several counties. Now we can say there's a positive case in the county or the city, but that's as specific as we can get with regard to HIPAA. And I know there's people in the public clamoring to know who has it and where they live and where they work, but we simply cannot release that information. We're subject to fine.
Dr. Sheffield?
Another, is this picking up well?
On the middle setting?
There you go, need to be middle setting. There's a patient in Cordell County who was positive. This patient called me on the way up here this morning because we exchanged phone numbers before. This person has been getting threatening harsh messages on social media because they are the patient infected, and somehow the name was passed around, not from us, because of HIPAA.
But this is another reason why patient privacy is protected, to help protect them against harshness from other people in society who think, well, if they got it, they must have done something to get it. How did they? And that's not the case at all. So that's another reason we emphasize patient privacy.
When you got the microphone, Dr. Sheffield, would you discuss the state's approach? What's going on with the state? I mean, I get 15 notices a day from DSHS and HHSC on what's going on with the state. Can you kind of summarize where we're going, what you see happening?
DSHS, and I asked Dr. Hellerstadt, who's the commissioner, how to respond to that question. DSHS is an agency for data collection, for advisement to the governor and to anyone else, health departments, medical personnel, private individuals. They're there for gathering information and the dissemination of information and to advise the governor on what steps to take. They were the ones who advised the governor about being a medical disaster, and that allowed the governor to go ahead and make his declarations. So for anyone who is interested, let me just give them, it's www.dshs.texas.gov/coronavirus/. If you just put DSHS coronavirus, it'll get you to that spot. And I've checked out that site. It has an incredibly long list of information that people would benefit themselves to learn. It has a connection to the CDC website that also goes into a lot of detail. So if people would avail themselves of this site and that knowledge, it would go a long way towards quelling a lot of rumors, false fears, and give everyone, like we say, be prepared but don't panic.
You don't mind, there you go. Right.
Say, be prepared, don't panic, facts, not fear. So that's what I'd say about your answer to that question.
I'm going to ask you to look into maybe you have the same crystal ball that Dr. Doggett has. Maybe a little cloudy this morning, the haze outside. I've been asked this 20 times, is the governor going to declare a statewide shelter in place or anything of that effect? Or, I mean, the answer is probably, I don't know, but.
So far the governor's been resistant to doing a shelter in place statewide. The point he makes is that in Texas we have a lot of urban and suburban areas, and we have a lot of rural areas. And right now there are a lot of rural areas who have seen zero activity on COVID-19. And one of the benefits for them is that they're so sparsely populated, they would be the last ones to get it, most likely, if indeed it does spread. So he's sensitive to whatever economic hardships might come on to those areas if indeed he did a statewide shelter in place. Now that's not taken off the table. That is not taken off the table. And just this morning, the president extended his guidelines until April 30th. And I've seen the governor usually follow those guidelines also as to where we are today.
Questions? Okay, thank you. Another question I have here, I'm going to get to my list of questions here. Probably the hottest one coming, other than comments, be sure to talk right in, it's not a directional or, talking the end of it there. I guess the hottest topic is the city council has, Dr. Doggett, you've looked at our ordinance at great length and I've talked about it. Okay, we are where we are today. What's step 2? What's step 3? What do we do next? Under what conditions do you recommend we go to those other steps? We could bring a big club, or we could have a big encouragement. So can y'all talk about that? I'm going to ask everybody to have the same.
I'll go ahead and talk first.
If that's great.
I've talked to Dr. Massey. He's our regional director for Texas Department of State Health, and he's for Region 3. And he's actually, I forwarded him our plan, and he's looked at it and said we had a good plan in place. He liked our plan. But we went over our demographics, our county population, et cetera, and so forth, number of cases. And I asked him that specific question. And he said he really liked what we had in place, and he thinks it's going to save lives.
Good.
But I told him that we were getting increasing numbers of cases, and that we'd likely get more as the tests come back in. And what he recommended was, before we do anything to make it any stricter, enforce what we have. He said, have them write tickets, have them warn people, have them. Well, we may be warning now. I hadn't heard of anybody getting any warnings, but he said enforce what you have before you go to step 2.
Let me address that, man. We have had some warnings,
Oh, okay.
and not ticketed necessarily, but have gone to people's homes and said, you have too many people in the house that are not related party. We've had some other situations where someone who had symptomatology isn't staying away, and so we've actually gone to that person's employer and talked to them about it.
But what he said is when you get 5 cases, start writing tickets and start letting the public know, start warning the public. But, we have to be careful before we start making things stricter. There are concerns about infringing upon people's liberties and rights to earn a living. And hey, I'm right there with you. I firmly support that. But, it may come to that, and that's something that I would recommend that the council take up. Number 1, let's enforce. Number 2, okay, what are we going to do when we get 10 or 15 cases? What are we going to do when we start seeing a couple of deaths? That's when you should probably revisit what is an essential business. Because right now, I don't know that it's necessarily fair, because we've closed some businesses, and I don't know that some of the businesses that are operating are that much more essential than they were. We might want to have like a level tier 2 of what is essential. You may want to consider pay at the pump only. You may want to consider going cashless, which would work for the majority of people, but some people don't have a credit card, but they can go buy a debit card and use that. That's down the road. That's as we get a little further into this, but that's something I would advise the council to take up. As physicians, we can't do anything, and there's really not much we can do in the way of treatment unless it's a hospitalized patient, and even then, we don't know if what we're doing is really effective. We're so far behind on the studies, but you guys can. You guys have the power. I made a comment that you couldn't lawyer or legislate your way out of this too, but as the mayor pointed out to me, there's not a medical solution either. This is a political solution, and that's what we need you guys to come together and decide when we're going to get stricter, and what should that be.
I'd like for each of y'all to address that same thing, and we're going to come back to part of what you mentioned there. You and I have had that conversation. I appreciate you bringing that information. Okay, what are some of the other things we could do, simple ones, but I'd like to get to the point where we say step 2 would be, step 3 would be, and particularly in that relationship is, what are those non-essential, what are have we allowed to continue that may not be essential businesses that we may have to look at as well. So if you just kind of go down the road and talk about that, I'd appreciate it.
Yeah, I don't know that I have anything major more to add than what Dr. Doggett was saying, but I think that I do see, and I think people would agree that are listening, I see people not following the current recommendation of the shelter in place.
So ticketing is what you're saying?
I would say, yeah, maybe increase warnings, and then, not too much longer start ticketing. I think you have to get to that point, because if people are continuing to not follow the rules, then it's going to get out of control much faster. It's just going to increase that graph, that curve. And then, that's the other question is, I think what we as physicians know is the way to slow this down and minimize is to minimize people in the same area, to minimize exposure. So what that means is fewer people out, and then so how do you make that happen, and that's the kind of question that I guess you guys need to make a determination on. But from what I can tell you as a physician, the fewer people that are exposed, the fewer people will get sick, and the fewer people will die. And I agree with what Dr. Doggett was saying as far as what is an essential business. It seems like some businesses, it's a hard line to draw, but some businesses are maybe not essential that are open now, and that's going to be the next step. Like he was saying, come up with some tiers. I think that's a great idea.
So instead of doing, when we get to that point, instead of doing necessarily what business, like naming a business out there, because I always want to know, am I going to be the next one? But necessarily, like one of the reasons that we made the ordinance last time was, or the declaration to say, like tanning salons, et cetera, is because of the one-to-one contact. Is that right, Brandon? Why that was pretty much the logic behind it. So if we've done that to all those, then what would be a similar type of business down the road? And we had a question to Carl. I'll let
Well, I did. Do you think because in our ordinance or in our declaration, we didn't define what essential and non-essential businesses are. Do you think that's necessary for us to define it? Because I see some businesses closed and others of the same type open. So.
I do think that's something to start thinking about now. Now, whether you want to make that change now, maybe not, but I think that's a good thing to start thinking about now, because when, whatever number the consensus is that next step needs to be taken, then you'll already have that in place.
Dr. Sheffield, want to address that too? And they're having trouble hearing the two of y'all speaking right into the mic, which they.
Over the weekend, I went over a couple of studies that we've had out recently. This one's from Imperial College in London. And they mentioned 1/3 of transmission occurs in households, 1/3 in schools and workplaces, the remaining third in the community. So 1/3 in the community, meaning it's not person-to-person transmission of disease that can be proven. It's just these people get it. 1/3 in schools and workplaces, and then 1/3 in households. So I see a point in the future where all of us are going to have to get more severe than where we are right now. It's just going to be demanded.
Okay. Dr. Hutchins?
Well, this is where I'm going to probably consider myself to step out there and be a Lone Ranger, based on what I'm hearing. The problem is we're only going to get past this thing when we develop herd immunity. Okay, that's the only way to get on the other side of it. Everything that we're doing right now is talk about attempts to prevent transmission. Okay, and that's good. We prevent the transmission, and we don't have the sick people, we don't have that huge spike, we don't overwhelm our medical system, okay, but where does it end? I mean, when do you say, okay, let's go back to work? Well, it's not going to be for 2 years, because we're going to suppress this thing down with, these social distancing measures, and get as extreme as you want to get with it. You're finally going to have to let people get out and get back to work so the economy keeps moving. And we don't get past this thing until we have the herd immunity threshold being met. And from everything that I'm reading right now, the herd immunity threshold for a disease like this that has a transmission rate of about 2.2 to 2.5, that's what we call the R0 value. And the R0 for this disease is about 2.5 max. And what R0 means is that for one case of transmission, 2.5 people are going to get the disease from that one person. You can't confer herd immunity until you have enough people immune to the disease to stop passing it around. No matter how long you sequester people from each other, you're just prolonging the agony until you get herd immunity, and you can do that through two ways. Everybody's got to get the disease, or you have a vaccine. A vaccine's going to be 2 years away before it can confer herd immunity. So, I mean, I hate to be, the guy that's bearing the bad news, but that's the truth. And you're going to read more and more articles about herd immunity, and I think everything that Trump is pushing right now, I can tell that he's talking to people who are preaching that, we've got to get herd immunity and we've got to allow a controlled burn of this thing. Our real goal should be to avoid what's happening in Italy. Avoid the situation where we have to make an agonizing medical decision on who we're going to help and who we're going to let go. That's what we don't want. But as far as my concern is right here, those patients that we're diagnosing with COVID in Texas, who are well and not in respiratory distress, that's good. They're now going to come out on the other side and they're immune and they can't catch it and they can't pass it on anymore. And we need about 60% of the population to be immune. That's what our herd immunity threshold for something that has an R0 value of 2.5 is. It's 60%. Every disease has a different R0. So measles has an R0 of about 15. One case of measles will transmit to 15 people. So you need 93% of immunity to measles before it will not transmit through your population. Mumps is something like 4. So you need about 70% of your population to be immune to mumps so that you don't get mumps transmitting. It can't go through. And we think the R0 value for COVID is about 2.5. So until we have a 60% immune population, COVID is going to continue to be pandemic. And we could continue to shelter in place until June, July, August. Then what? Then you relieve those social distancing measures. Then you have your spike in September, October. Okay? So we're going to have the spike. We just need to try to let that become as controlled of a transmission as we can possibly do so that we don't overwhelm the medical system. And I know.
How do you do that? How do you do that?
Well,
Just to support something Jeff said, Dr. Fossey, he's saying, let's get ready for the second wave because there likely will be a second wave.
There's going to be a second wave. Until you get the herd immunity threshold met, there's going to continue to be problems with COVID. How do you do it? I think that you have to look at the specifics of this disease and make the best decisions you can once you know the things about this disease. And what do we know about it? Who does it kill?
I see you pointed out.
Everybody's got a few gray hairs.
Oh, it's past. Okay.
Sequester the old. Keep the old and the young away from each other.
So some of the measures that Ricky put in our declaration were good then, about giving special privileges or whatever to seniors, that sort of thing. Was it good for us to do that then? Maybe long term.
Yeah, I mean, the older you are, the more you don't need to catch this thing. I'm 52, so my wife's going to be a lot better off than me, statistically speaking. She's 42. From what I've read, anybody under the age of 9 hasn't died from this thing yet. I think we've got to get to a point where we kind of don't worry too much about the kids, and we worry a lot about the old, and we try to start making policy as a public that keeps the old away from the young. I'm reading a whole lot. I've got articles here about there's a good argument for putting the kids back together in school. Very controversial, but there can be significant herd immunity generated through an immune younger age population, and I think that's something that would have to be talked about, but we need to start thinking about how do we get to herd immunity. And that's where the conversation needs to go as far as the next step.
Dr. Doggett, I pulled you the last on this list of that question particularly, and a lot of reasons. One is I didn't say this earlier as our health official. I want to say to you, I appreciate the fact that you are accessible like you are. It's everybody has a business. You have a business like these other folks do, and getting calls from me and Alan and everybody else in the middle of the night is a big deal. I appreciate what you're doing for cities. Thank you very much for that. Would you address the same question then about, well, I'll give you some free in there.
Sure, glad to be here. And what Jeff said, he has some valid points, and there are a lot of physicians that feel like Jeff. I think that's a minority view. Most of the doctors I've polled here in town, support shelter in place. That's basically our only tool. When I was a kid, and it got out that somebody had chicken pox, well, the mothers would all get together and have a Tupperware party, and so we'd get the chicken pox and get over it, and that's kind of the way we built herd immunity. And and it can work in some instances. For the Native Americans and smallpox, it didn't work out too well. They almost got wiped off the map. I mean, their population dropped 95%. So there are pros and cons. I mean, what he had some valid points, and there's a substantial portion of the community that agrees with him. But shelter in place works. And he's right, shelter in place for a week or 2 or 3 is not going to work. The models developed, Dr. Sheffield sourced the Imperial College of London. They recommend 3 months. And I have a, well, I'll just show you.
Oh, it's Carl Rove. Got the whiteboard.
This is what Clay Jenkins presented in his, when he did his disaster declaration, and it talks about flattening the curve. This is essentially if we do nothing, the red. It's color-coded, so you don't have to be a scientist to read this.
I'm colorblind.
The gold or yellow curve is if you shelter in place and do social, if you do social distancing, excuse me, I misspoke there. Still overwhelming. The black line, which is the number of available hospital beds in Texas. The green bluish line at the bottom you see, I've said before that was shelter in place, but that's really more of a Wuhan style lockdown. I mean, that's where they really lock it down there. But as you see, the curve stays flat, and we don't overwhelm the number of beds. Communities that were early adopters of shelter in place, limiting mass gatherings, et cetera, and so forth, their velocity, their trajectory curve is linear instead of exponential. There was something going around on the internet, Make America California. And I don't recommend that in a lot of instances, but in this one I do.
Yeah, none of us would either.
And we've passed this out among the members here. Basically, it starts off at day 0, and that's deaths per million population, and this is plotted against days since the 10th death. If you'll see Louisiana, New York, New Jersey, Washington, you can see how their curve is sloped. California, they implemented some of these measures early. Apple, Google, Facebook, Twitter, major employers in California, they sent people home early, and that's why their curve is linear instead of exponential. I think shelter in place is the best tool we have. It's not going to be a quick dose of medicine. It's not going to be short acting. It's going to likely be long acting. We're likely in this for the long haul, unfortunately. None of us know for sure. None of us have the answers. We're flying by the seat of our pants and just trying to survive. Dr. Fauci, his estimates are that we're going to have 200,000 deaths from this. And I've been tracking a think tank of 17 epidemiologists and experts, and they all give their estimates too. And among the 17, their numbers come up to about 260,000 deaths. Worst case scenario and best case scenario, they range from 30,000 deaths to 1.1 million. So it's going to be somewhere in between. I think shelter in place is the best tool we have. And how long do we administer it? That's up to you. The data's out there. All we can do is present the data. But I respect Jeff's viewpoint, even though I somewhat disagree with it.
Yes, sir.
I want to draw a line.
Alan, speak up real loud. Thank you.
Your scenario and his, and say probably somewhere in the middle. I'm just guessing as obviously not a professional. if you accept that as possible, is time on our side, and does climate help us? Because I've heard things that say warm, dry, warm, moist versus cool, damp, cool, and I don't know if there's any data that will support either one of those.
We don't have a lot of data, but early data does support the fact that our climate is less conducive to COVID-19 than the northern climates, but it's still there, and we're still on an exponential curve at this point. But you're right about that.
When will we have better or more definitive information about how that?
It's fluid. It changes every day. Since this started a few weeks ago, it seems like months, but my position has evolved. Early on I thought, hey, we're okay, we're isolated out here in Hooterville, and this isn't going to come to us. And actually, Dr. Massey, my source at Texas Department of Health, when I initially contacted him and said, hey, we're closing the schools, we're doing this, we're doing that, he said, well, okay, but he said there's really no data, to support these non-pharmacological interventions in a community that doesn't have spread. Well, the last time I talked to him, and I mentioned that to him, he said, well, hey, everything's changed since then. This is a whole different deal. We're in a pandemic. There's a beginning, a middle, and the end. And he said, we're getting closer to the middle, but the end's a long way off. I don't know if that answered your question or not. But it's fluid. It changes from day to day, just like the number of cases of COVID.
Anybody else?
I got a quick question. Anybody wants to take it. So if we are in a scenario where we decide that we're going to shelter in place, either more restrictive, less restrictive, what are we going to do in the next, say, 3 to 4 month period? Somebody kind of can walk me through this scenario. I know at this point, I think what I'm getting is we all agree on 2 things are happening currently. Number 1, we're trying to reduce the strain on the medical community, and number 2, I think just limit the community spread. But if the scenario of 3 or 4 months, if we continue to shelter in place and distance ourselves, what happens when we open the gates back up and everybody go back to living your life?
One of those models addresses that, and my colleagues can address this also. What they do is they talk about sheltering in place for a short time and relaxing those measures for a short time until the cases start to rise again, and shelter in place to drive the caseload down again until you see, and it's a crystal ball, when to relax again and see when the cases start to pick up, then shelter in place again. And I say that's one way to try and lessen the economic cost on your business owners, and also to take such a strain off your society in general. That's a model. Doesn't say it's proven, but they're thinking that's a possibility if some people want to try that. Everybody else, y'all suggestion?
That's logical, but I don't know that I see that happening. It's logical, and there's going to be some that support that, and it makes sense. But it's really hard to start, stop, open your business, close your business, open the school, close the school. That's difficult too. But I know this is putting economically a strain on everybody. Like Jeff said, their numbers are down at the ER. My numbers are down. People that would normally come in and get their preventive health maintenance exam done or get me to look at a skin lesion or something like that, they're saying, hey, I'll see you this summer. So our numbers are down too, and I think that's kind of across the board. We're all affected by this, and it's devastating. And I don't have a good answer for how we're going to get through that. I don't think they can print enough trillions to ease the pain for all of us. But I think we're looking at most likely longer term shelter in place. But I don't know. I'm not in charge. That's above my pay grade.
I guess let me kind of take the question. The next thing really what I'm trying to get at is, what do we hope is going to change from a medical standpoint in 3 or 4 or 6 months? I know until we talk about, you talked about the address herd immunity, or I know we heard the number of 18 months possibly for a vaccine to come online at the earliest. Is that is that the benchmark really 18 months? Or I know, is it the July, August kind of talk about the timeline? Why are these some of the dates we're hearing? What's really going to change from a medical standpoint, whether it's July, August, or in 18, 24 months?
Well, that's just kind of the natural course of a pandemic. It more or less runs the bulk of its course. The bulk of the cases will be will be gone by that time. It'll be warmer weather. I mean, things will be more in our favor then. They're working on a vaccine. I don't know when they're going to have it ready. We may have a more definitive treatment by then. But we got through SARS, which was a coronavirus, and we got through MERS, the Middle Eastern Respiratory Syndrome. It was a coronavirus, and in some instances, those had a higher mortality rate. They were a little easier to diagnose, though, because you didn't have this 5-day period where you're asymptomatic. People got sick, and they got real sick, and they got that way in a hurry. With this, it's insidious, Somebody in this room could have it right now, for all we know. They're asymptomatic. It's difficult. There's no easy answer. I don't have the answers. I don't know that anybody does. We're just trying to do the best we can to get through this, and the consensus is that the best tool that we have right now is shelter in place. Now, I'm not saying everybody agrees with that, because there are differing viewpoints, and I think it's good to come together. I think it's good for people that have differing opinions to get together and talk, because somebody may come up with a good idea, and we're all here for the common good, and we're all going to have to sacrifice for the greater good for us to get through this and come out on the other side, and we will come out on it, but nobody has all the answers, and I don't have all the answers. Jeff may be right, I may be right. It may, like Alan says, it may be somewhere in between. But we all have a common goal. We all want to see our patients and the community get through this. We're all on the same team. I'm not adversarial with anybody in here. I'm on the same team. We just got to pull together and do the best we can in a difficult situation.
Brady, thought on your question. I think one thing that will help quite a bit in the next month or two, or however long it takes, is to get quicker testing. I think that would be a huge game changer for us if we could find out somebody's positive or negative in 5 minutes or 15 minutes, because then, it's very challenging, if not impossible, to give advice on what to do when we're 5 days behind or a week behind. It's really hard. So this new testing that's coming out, if somebody gets even a sniffle and wants to come in and get a test, and we can do that in quarantine, so they'll still get the disease, but and again, the vast majority of people can recover at home. So that could potentially, add to the herd immunity that Jeff was talking about. But then they're not going to be exposing people for the next, several days. That we can make that really available. That would be a huge game changer.
And so is that something you agree, Dr. Nash, to kind of play for the next 3 or 4 months? Is that we're just going to learn more about the virus?
Absolutely. Time and learning more about it is going to help us to decide, what's the best approach to try to, get things going again. One other thought, and it just kind of came to me as people were talking, but if at some point the shelter in place, we're saying, okay, it's time now to start going back and start restarting, maybe we do ask people over 60 to continue to shelter in place longer instead of everybody all at once. We say, okay, well, you can reopen schools, but we're going to, if you're over 60, we still, the ordinance is still shelter in place, and maybe try, and then maybe over 70 shelter in place, and try to gradually by age consider doing it that way.
Dr. Hutchins, you didn't have a chance, and then Alan's going to ask a question. You didn't have a chance to answer his question as well.
I'm sorry, to Brady's question?
I think
Yes.
it's been addressed. I was just kind of wanting to know, just because I think what people need this time is hope. They need hope, and I don't think we can get in a position of saying the deadline is, like the President did earlier, Easter. Because I think you can't be that definitive, but I think people just need some hope that here are some markers for our foreseeable future that what we need to be looking for, why it's important, whether it's 3 months or 5 months or 18 months, what it's going to develop, what's going to change in order for us to be successful on the back end. So that's what I'm looking for, is just people need hope and kind of that insight from you guys in the medical community, what things we are going to be working on in the community to get over this and be successful.
I totally agree with what Miranda just said. Testing is going to be the key so that we can really track this thing epidemiologically. The more I read about it, the less scared I am of it, to be honest. Fauci came out today. First thing I saw on my computer was Fauci warns that 200,000 Americans will potentially die from this. I said, 200,000? That's awesome. What is the percentage? We're talking about a death rate in this thing of 2, 3, 4%. You know, in China, they reported 3.6% death rate, mortality. Oh, we're looking at much, much less than that, okay? And the reason that our death rate is so scaringly high in this disease is because of the lack of testing. And who have we been testing? Those that are sick, those that are going into the ICU, okay? What about all the ones that didn't even have symptoms, that probably are already out there and already in that cohort of immunized people who've had it and done and gone and had minimal symptoms? They're not added into that cohort. When we start to look at this disease, it's going to have a less than 1% death rate already. And now a lot of these experts that I'm reading studies on are saying we're going to be looking at, you know, maybe less than a 0.1% death rate from it. So if Fauci's saying 200,000 Americans could potentially die from this, then let's all go out there and start licking door handles right now. Let's get over this thing, get our economy back moving, okay? Because 200,000 Americans out of 330 million Americans is a 0.06% mortality rate from this disease, and the flu has that. But, you know, flu's still going to kill more than this thing. You know, we're just getting a big spike in our deaths right now. But then we're going to get on the other side of it, and it's going to be done. And next year we're going to have a lot more flu deaths than we're going to have coronavirus deaths, and nobody's going to be talking about it.
Alan?
And y'all may have addressed this, but I didn't catch it if you did. I know some of the flu strains have adapted, changed, I'm not sure what the right word is, through the of their lifespan. Does this virus do that also? Because the testing.
We don't know.
Likely it is. Likely it is changing. And Dr. Fauci said last week we're going to have 100,000 deaths. You know, next week he may say we're going to have 400,000 deaths. I mean, we don't know. We don't know. But if we did nothing, I mean, there's no doubt. I mean, the curve I was showing you with the red, that's not numbers of cases. That's numbers of hospitalizations. That's 700,000 hospitalizations. I mean, the measures that we put in place are already helping. And there's no doubt that herd immunity is going to play a role in this down the road somewhere. But we can't just open the gates, I don't think. I don't want to do that. I'm not going to open the gates.
One of the things, go ahead.
One thing real quick, and I kind of want to go back and kind of message of hope for people. Do we have an opinion, y'all, as to, I mean, is it kind of I don't call it a blessing, but out of all the times of year this we could be experiencing it, at this time of year, being early spring, going into summer, is this kind of the optimal time for us to be dealing with this versus?
I think so. If there is an optimal time, I think we kind of lucked out on that as far as our particular population being affected is in relation to some of those up in the Northeast. But we are catching a break with that, I believe.
Carla?
Well, I never predicted that when I ran for this office I would make decisions that affected people's livelihoods. I thought I would affect their tax rate maybe, but not their livelihood. So I did have the question as we look at our declaration and where we should go from here. I noticed yesterday that McCoy's came out and they're limiting 10 customers at a time in McCoy's. HEB had already put something in place a couple of weeks ago, 100 customers at a time. So in lieu of closing businesses, would it help if we limited how many customers were in a business, like we see some of the businesses doing, because they hate to close a business?
Yeah, there's no doubt that that'll help. You know, the first time I went to McCoy's and there was a couple of people standing outside, I walked up and they said, "Hey, don't go in yet." 2 people walked out. They let 2 of us go in. I mean, anything we can do to decrease the density of people and increase their social distancing is going to help. I mean, that's better than a sharp stick in the eye, but I don't know if that's enough.
Dr. Sheffield?
This entire point about sheltering in place is simply to reinforce social distancing and to a lesser extent personal hygiene measures. So that's exactly one of the better things that could be done that you just brought up.
Okay, and something that I know came up yesterday in one of the social media post, and I know some other towns have limited families when they, instead of taking your entire family to Walmart to shop for groceries, choose one person in the family to do that. And I saw people say, well, I'm going to Walmart, I'm taking my kids, they like to pick out what they want for this coming week. Well, to me, that's kind of selfish that you're not thinking about your kids or the other people in the community. If you could limit, and I know there's people that can't limit because they don't have babysitters, but I know that some communities have done that. So is that something we can do too?
Maybe, and if you know an elderly person, go shop for them. Keep them out of there. That's something we can do.
Okay, Ricky?
Part of this, I guess the three of you can probably address, may have to do it individually, but can you talk about roughly the number of outstanding tests that we're waiting on results right now? And also any, I guess, your daily trends, what you're seeing with new people coming in, presenting with symptoms and qualifying for testing. See an increase in those numbers, or are they, what are they doing?
If you look at the COVID-19,
there's a question from Facebook. Let's add to that so I get this done. As well, the numbers of people tested and the numbers of positives results back, and if you add that as well. And negatives, yes.
Yeah, in Texas, if you look at the on TDH, they've got a COVID-19 tracker. It said there's 24,000. This is right now 25,483 total tests. The results are back on 2,552 of them.
10%.
So as these numbers, as we get test results back, you're no doubt going to see a spike in number of cases.
Do you have any idea what that roughly, I know you may not know exactly, but roughly that number is for Erath County?
I can find out.
I think it's about 100. Well,
Yeah.
I'll say this first for us. I don't know about the rest. For Stephenville Medical and Surgical Clinic, we were right at 100 as of Friday, and so, and I worked Saturday, so I'm pretty sure we're quite a bit. We're right at 100, and then we've had the 3 positives.
Yeah, I think SMSC is doing a lot of the bulk of the testing. The hospital's doing a little bit. They're not just testing everybody that comes through the door. You have to need testing. You have to have symptoms. You can't just say, hey, I'm curious, do I have COVID? And they're going to send you out the door. SurePoint's doing some. I don't know their numbers. I expect it'd be maybe similar to the clinic, so maybe I would say less than 300 tests in the county, and that'd be pretty safe to estimate. Now, if we tested everybody that wanted to be tested, it'd be 15,000. And some of this may improve. When the clinic comes online and gets their rapid testing, I think you're going to see that go way up. But those ID Now machines are about $10,000, I think. So most of us just can't pop and buy one of those. I don't know if SurePoint has that now. I think they're sending all their cases off.
One of the things we may be doing as a council is recommending that we participate in that to get them here.
But I'd say less than 300 tests, probably. That you'd be pretty safe.
With 3 positives.
Yeah. And the trends, are you seeing fairly flat? Are they increasing?
As far as the number of people that want to get tested, yeah, I think it's pretty steady. Last week, there were some days that were very, very busy, and then others that were a little slower. But I would say overall, the last 2 weeks have been pretty steady on the testing. This last week, we were getting tests back quite a bit quicker than the week before, which we still have some pending from that week. But that's kind of, and then this week, it just kind of day to day. There weren't a ton on the schedule when I left this morning, but things can come up pretty quick.
I'm just going to add 300 tests doesn't sound like a lot for our county of 42,000 people, but we've got 25,483 for Texas, and the population there. I agree with Jeff and Miranda that as rapid testing becomes more readily available, that's going to be a valuable tool, because we can test those people, and when they have it, we can isolate them.
Okay.
One more question, Brian Lee. Alex wants y'all's opinion as, from a medical standpoint, what do you hope that we and the general public learn from this experience? Once we overcome it and we're successful, what is the message we all need to learn from this?
I think we're going to learn that we can all work together. I mean, we've seen consistency with the Congress and our elected, representation in Washington as they've unanimously voted for a relief bill. Who would ever thought you'd had a unanimous vote on anything nowadays? But I think we're going to learn that we can all work together, and whether we agree or disagree, we have a common goal. We can come together and we can come out on the other side.
I think how important our small businesses are. I just really want our small businesses to recover from all this.
And for me, we've become somewhat complacent in our healthcare world because we think whatever we've got, a pill's going to fix it. Whatever's wrong, a surgery's going to fix it.
That's a good point.
We've got too much of that in our media, on our TV shows. And here we're brought back to the harsh realization that there's some very serious diseases out there to which we have no defense. And we just have to go back to the good old-fashioned, keep your distance, keep your health, keep your personal cleanliness. And then we have shown that our country and our parties can still come together to fight this thing on behalf of everybody. So out of this bad, there's going to be a lot of good. And we'll, as we always do from pandemics and epidemics, we're going to learn more from this one on how better to approach the next one. Because there will be a next one at some time.
Okay.
I got one. I want to go back. So you said $10,000 for a piece of hardware that would help conduct the test. What about soft cost or consumable cost that would go along with it?
Jimmy's working on that now.
So we're going to get that number?
Yes, yes.
Okay.
We'll be presented to council. We'll be up to the medical community to tell us where it should be, how to use it, et cetera. But I think that the council is probably going to look at doing something like that to see.
Is the equipment available right now?
Well, I checked, and for my office, it's on back order, but I don't know.
We were told that that it's being distributed, but that there's a list, and basically you're on a list, and you just kind of have to wait till it's your turn to get one.
Yeah, if it comes down to me or somebody in New York City getting one, I think they're going to send it to New York.
We may need some help with that, Dr. Sheffield, getting some bumped up the ladder just a little bit.
Nothing would make me happier than, 3-4 months down the road, this all blow over, and people say, Dr. Doggett was full of it. We didn't need to do all this.
I've never told you that before, I think.
If our measures work, if our shelter-in-place works and this blows over, we won't know whether it was that or whether, it ran its course or what. But that's my hope, is for people to come up to me in a few months and say, we knew you didn't know what you were talking about. It wasn't as bad as you thought. That's what I'd love that.
I want to just I'm sorry.
Go ahead.
I had just clarify some information from Jimmy Chu, who all the testers are supposed to report to for how many tests have been run. As of, I guess that was yesterday, the results are there's 135 to 140 people tested so far. Is also we're about half of what we thought.
Do we know for sure?
I just verified we've done 107 tests at the clinic.
How many of y'all done? Do you have any idea?
I don't know, but
Last I heard was about 38. This is the last time I heard.
30, 40.
So, as of last night,
Do we know if SurePoint's reporting?
SurePort replying? Are they reporting? SurePort is reporting.
Okay.
So they're apparently, last I heard, they were like 11 or 12 is all they'd done so far. So basically, y'all are the ones, you're probably the most likely one. One other question, Gerald. I'm sorry, I interrupted you twice now.
That's okay. I'm not sure it was that important. It would just seem to me, based on what you guys are telling us here, two-pronged deal. One, the herd immunity over the long haul is where it's going to be at probably. In the meantime, and this gets to a little bit of what Alan was talking about too, it's somewhere in the middle. In the meantime, the best thing we can do right now is shelter in place, put a little more teeth in it, protect the people over 60 and those that have underlying problems as much as possible. In other words, keep them separated out. I think somebody said separated from the youth as much as possible until we get through this thing. Is that correct? Is that what I'm hearing?
I think there's no doubt that herd immunity eventually is going to play a role in this. There's no doubt about that. But, as a physician, I want to keep as many people alive as I can right now.
So the best way to do that is to shelter in place.
Shelter in place,
keep
follow
people away from
CDC
each other.
guidelines, wash your hands, stay home, just do what we're asking you to do, basically.
I agree with distancing. I don't agree with more teeth. I think this is America. We can be a government that leads with a carrot, not a stick. We're not a communist nation. So, I know we shouldn't be out partying. I agree that there are times that we really need to more heavily discourage certain activities, and I'm in agreement with that. But I don't agree with criminalizing me having my next door neighbors over for dinner.
Anybody else?
Our clinic has a all is forgiven policy, and I want to tell you what that means is that we sit around, we talk about everything we want to do that we think would work, and we have a all is forgiven. That means, okay, if you thought this idea was going to work and it didn't, all is forgiven. If you thought this idea was going to work great and only worked a little bit, still all is forgiven, because y'all are non-medical people. You're being tasked with the almost impossible task of trying to direct a civilian population through a medical pandemic that we have never seen before in our career and almost in history. So I think you should also pat yourself on the back and give yourself a break. All is forgiven. You're trying to do the right thing here in a very impossible situation. So I just wanted to tell you that's the feeling we have at our clinic, and I want to pass that on.
Thank you, sir.
I agree with it.
And overall, Jeff and I are a lot more alike than we are different.
Absolutely.
We have the same goals.
Oh, absolutely.
We have 8 minutes left, and I have something I want to talk about the council towards the very end. I'm going to let every one of y'all just kind of have a summary statement, kind of run trial court or any of that kind of stuff. Just give us some summary and particularly address, if you would, in your opinion, what's the next step if it gets worse, or is there a next step?
I think just echoing what was said earlier, I think the next step would be to potentially ticket or make it a little bit more strict on the shelter in place, and then you might even again kind of revisit which businesses are essential and which are not essential, and then whether people over 60, we need to have some stronger guidelines, and for that population. I would just encourage anybody and everybody to follow the guidelines, and we can make this better if people will follow the guidelines, follow the ordinance, and try to minimize the risk to the most susceptible populations. I guess what I would like to see happen is that our hospital doesn't get overrun, and that we aren't in a situation where we're having to use anesthesia machines as ventilators. That's what scares me, and so that's kind of my goal. And yeah, more people are going to get this. Hopefully, the majority of people that do can recover at home and are not going to get real sick. But I worry about what happens when we can't send someone that needs a ventilator to Fort Worth, and then we're running anesthesia machines as a internist who's never run an anesthesia machine before. So I do think it's something to be scared of, be aware of. I don't want people to be panicky, but it's something that you need to take seriously.
Very, very difficult situation. I consulted an expert, and he said, enforce what you have. And that's difficult. I'd hate to be that police officer that had to ticket somebody that had lost their job or was laid off and didn't necessarily have the money to pay a fine. But I think it's going to take something like that. But on the other hand, I empathize with Jeff's view. I mean, I'm a big proponent of freedom and liberty, and where do we draw the line? I don't know. I don't have a really good answer for that, but data tells me, it leads me to believe that shelter in place is our best tool. And the expert that I consulted with from TDH said, what you have is fine, enforce it for now. And then I think maybe behind the scenes y'all can work together and prepare for what's coming down the road, maybe for what's more essential and less essential. I wouldn't touch that with a 10-foot pole as far as naming a business myself, but I think we've got a good plan. Let's move forward with it.
So we'll continue to say, extreme sequestration of the elderly population. Those are the ones that are going to die on us. I agree with Miranda, and I agree with almost all of what Kelly says too. We're all in the same boat on this deal. But I know that herd immunity is what's going to take to get us on the other side of it. And it's going to have to be a controlled burn. We don't have time to wait on a vaccine. Our economy won't hold up to that. Okay? All the small businesses are going to be dead and gone, and we're going to be in, the worst depression we've had, even going all the way back to the Great One. If we try to, hold these strict shelter-in-place guidelines until a vaccine comes out 18 months from now. So you've got to ease off on the shelter-in-place at some point, and we're going to have that spike, and we just hope that it's a controlled burn and doesn't overwhelm the medical system, because I agree totally with what Miranda just said. We don't want to see all of our ventilators being used and our anesthesia machines being used as ventilators in our hospital. Right now, we don't have a big issue in this whole region, including our referral region to Fort Worth. So, I'm actually ready to start seeing some of these patients. Most of them are going to have mild diseases. The more we read, the more we know. The more we know this thing, in at least 80-90% of cases, it causes a mild, common cold type illness. So, does it cause respiratory failure and death? In some, yeah, absolutely. Should we be scared? Yes. I mean, am I personally scared for myself and my family? I am. I'd be lying if I said I wasn't. But I also know that I'm also scared for our economy and what this is going to ultimately do if we keep reacting out of fear rather than the reality is the vast majority of us is going to be okay. I think we're looking at less than 0.5% mortality rate on this disease.
Dr. Sheffield? Yes.
A few notes I had is that we're in this for the long haul, and again, our American society is so ready for a quick fix, immediate release, and we're in this for the long haul. We're talking about efforts to mitigate this while we try to move to suppress it, and the shelter in place is what's going to work. It's just how long term will we have to do it, and how will we have to slow and stop. That's a decision y'all have to make. I'm sure all four of us are going to get this disease before all said and done, because nobody has an immunity to this. When we look back, we'll realize all four of us got this disease. But we'll get through this and be prepared, don't panic, and let's talk about facts and not fear. And that's all I have to say, and I thank you for the opportunity to be up here today.
Well, that's exactly why I asked for all of y'all to be here, is to dispel fear and to give facts out. And there's more than one side of the story we've seen today. And the facts, everybody has their own facts too. So the bottom line is it's our job to legislate what we do. These docs, I told all of them, it is not your responsibility to tell the citizens of Stevensville what to do. It's our job to do that. And that's the tough part. And we appreciate so much what y'all did today. I know you've been on shift, these 12-hour shifts, and I understand. You see his eyes kind of drooping a little bit. He probably pulled it 2 or 3 days in a row doing that. Miranda, you run a business, not only that, but you have a bunch of patients. My wife's one of them. She appreciates you more than I can tell you. Dr. Sheffield, you came a long way to come give us a perspective from Coriel County. Thank you very much. And Dr. Doggett, I just can't tell you how much I appreciate what you do for the city of Stephenville. The last thing I want to say is I'm going to appoint an ad hoc committee, council members, to work with city staff to look at our current ordinance and to come up with a what's next, if there is one. And so if you're interested in doing that, please see me as a council member, and I'll get with you and Alan, and we'll make that appointment. And I'm going to give you the last thing to say. If you have something else you want to give us, some advice, that's what you get paid the big bucks for.
I appreciate that. And let me clarify. I'm not saying we need to shelter in place 18 months. I mean, I think we'll all starve to death before then. I mean, there's got to be a happy medium somewhere. And the models show 3 months. Will it be 3 months? I don't know. I hope not. I don't know if we can stand 3 months of it, but that's what the data supports. Things may be a little better. It's a fluid situation. This may be better than we're hoping. I don't know, but it looks pretty bad. We just got to do our best to get through it. There's no doubt that it's wreaking havoc with our local economy and state economy. 1 in 6 jobs in Texas is oil field related, and I had a patient that drove through Midland, Odessa last night, and he said it was a ghost town out there. So I mean, it's already going to markedly affect us. You know, we're probably going to have to dip into our long-term state reserve funds to get through some of this, but there's no easy answer. There's no easy answer.
Dr. Doggett, two-tiered shelter in place by age, so that you're looking at, say, those over 65, those under 60,
that's something to look at. I mean,
or
that's
something like that.
Yeah, that's
Totally
reasonable.
different type of
And
shelter.
it may be when we get a little further into this, that may be something that we look at. You know, really protect the people that are more susceptible. But right now, I think what we have is good. But that's I'd certainly be open to something like that down the road.
Alan?
Thank you.
What Dr. Sheffield touched on is one of our biggest problems. We've become a microwave society. We want everything done, and we want it done right now. We are not patient. We don't wait well, and we don't want to wait well. And that's one of our problems, is we're not used to dealing with something like this that we don't have instant answers for, or a vaccine in place that you can give me a pill or a shot and take care of it. Y'all are all familiar with the old joke. How do you determine whether it's major surgery or not? Whether it's on me or you? That's how you determine that. And you talk about a controlled burn, okay, that doesn't matter unless it's my dad or my mother or your grandmother or somebody like that catches this, and then it's fatal for them because of that.
Those are the ones that don't need to get it.
Those are the ones that we must do our best to protect, whatever that takes. And we, as day by day, we learn more and more. And we're in a terribly awkward position, as Dr. Sheffield said. We're a bunch of amateurs trying to make decisions that impact not only our lives, but our livelihoods of the area, the community, and sometimes wider reaching areas than that. And we appreciate y'all's time and your input. And I'm going to tell you right now, they don't pay us enough to make this.
I'll say that also that we have agreed to have some more town hall meetings. And we're going to ask the same people, if you're willing to, or some others in town, if you have recommendations, can participate in that, where we'll have a panel up here. And I just had just a few of the questions. There will be dozens of questions asked during that opportunity. I'm not sure exactly where we're going to do it today. We pushed it off probably 2 weeks. Probably 2 weeks. So we might get back with you. And also, whoever gets put on the committee, this ad hoc committee, I'll let you know that these 4 folks have agreed to be always a resource to you, to review stuff, get some suggestions, et cetera. So we'll help make a better decision going down the road. Anybody else?
Just a suggestion, Mayor. One of the things that I've had people talking to me about a lot, and that is the lack of flow of information. We get a lot on the national and on the state, but we don't get very much locally. Brady was talking about hope and so forth. The town hall meetings that we're doing are very good, that Alan and the staff are putting together. I think maybe if we had every day or 2 or 3 days or something like that, perhaps you and Alan together, just doing a Facebook, a quickie saying, folks, this is where we are. This is what you need to be doing out here in the shelter in place. And we've had 1 or 2 more positive tests, or 3 or 4. We've had this many. Hang in there. We're going to get through this together. And if we did that every day or every other day, it's a way of communicating to the people out here. And there's a lot of apprehension out there because they don't know.
That's a good point, and I know that, and Al and I will get together and discuss that. I've been asked by the newspapers to write some more information and get public information out there, so that's good. I appreciate that a lot. And just for the record, we've had, in the county, we've had 3 positive results out of 140 something who've been tested, and 2 of those were outside the city limits of Stephenville. So we've had 1 within the city limits of Stephenville. Is that correct, Al?
That is correct.
So that give you the perspective. So just for your information, also apply a little bit of what you were saying earlier, Dr. Hutchins. So with that, it is 11:49. I truly appreciate y'all's help. Thank you so much. You took a lot part of your day. We're staying adjourned.